It's really a pleasure to be with you, with everyone today. I wish I was there in person. We'll be talking about the role of the workforce in implementing choosing wisely in cancer care. And this, as you know, this project was also done as a task force from OOTIC. With some collaboration from my colleagues and Queens. I don't have any conflicts of interest, and it's really about starting a conversation. And the current reality is that by 2040, 67% of annual cancer cases will be in low and middle income countries. We know that after the pandemic, there was the progress that was previously happening in declining poverty rate globally has stopped. So we're seeing more poverty now. And we know that cancer treatment is very expensive. Even prevention and screening sometimes can be costly. Here, looking at a high-income country as Canada, and you can see the cost of radiation and chemotherapy from 2005 to just 2012 is kind of skyrocketed, and that trend is continuing. And when it comes to weighing the costs and benefits of economics of cancer care, we know that oncology as a profession is really a calling to serve patients with cancer, but it's also an important component of their health economy. And there has been a lot of changes in the last decade with a lot of new medications and advances in technology. These have profound impacts on hospitals and doctors, and most importantly on patients and their families. And even those drugs and technologies are being used more also in low and middle income countries. One of my colleagues, Dr. Bishal Gwali, will probably talk about this important concept where the cancer moonshot was started in 1971 in the US to bring drugs and technology to combat cancer to the cancer ground shot, in which we would like to use what we have wisely so that we can get the best outcomes. And when it comes to valuing cancer care, there are several ways of achieving that goal. One of them is choosing wisely, as you have seen. We have India, Africa, Philippines, and Brazil, and others coming. And then also coming up with ways to assess the clinical benefits of new therapies. So for example, for drugs, so we have the ESMO scale and the ASCO clinical benefit framework, which we have been talking about in several other ventures, and we hopefully will have our own in Africa as well. So what do we mean by high value care? And the relationship between value and quality is that we mean providing the highest quality care at the lowest cost, and that's a value equation, which is quality over cost. So you can improve value by either increasing quality or decreasing the cost. And one of the common quality problems, if we divide this into quality and cost for value, is underuse, overuse, or misuse of treatments and technologies. And so the common examples that the workforce can do, and these are quality problems. So for example, underuse is what do we mean by that? Is failure to provide healthcare services where it would really need to benefit. Examples is not using neoadjuvant therapy for rectal, breast, or bladder, or underuse of supportive care measures such as antiemetics to make or pain medications to make patients' quality of life better. Overuse is when you are using a healthcare service under circumstances where it's the potential for harm exceeds the benefit. So, for example, giving chemotherapy in the last months of life, and that was one of our recommendations in choosing wisely, is not to give chemotherapy for those who are already about to die or have worsening performance status, or if in hormone receptor positive breast cancer using aggressive chemotherapy, or overuse of supportive care measures such as giving growth factors for patients who are not at risk for neutropenia. And the misuse is when you are actually providing an appropriate service, but you are not really preventing the complications and the harm that can happen to the patient. So in the end result, the patient does not get the full benefit. And we see that very common in avoidable complications of surgery or medication use, for example, not adjusting for renal or hepatic dysfunction. As you know, with Dr. Van der Poel is a very close friend of mine, and she's one of the leaders in the Choosing Wisely Africa. And together we sat down after was aortic Mozambique in 2019. That's the 12 of us, and we said, like, what can we get some examples from our settings about underuse in clinical cancer care? Like, we're not using enough hormonal therapy for luminal breast cancer, not using olanzapine for nausea, vomiting, not using neoadjuvant chemo for rectal cancer, and not using a neoadjuvant for triple-negative breast cancer, giving platinum such as cisplatin without checking magnesium or potassium and replacing them, not giving palliative care in advanced cancer. And so these are just some of the examples. Overuse, there are multiple examples, such as giving combination chemotherapy in stable metastatic breast cancer, which is actually one of our recommendations in Choosing Wisely, and giving chemotherapy for diseases that do not respond to chemotherapy, such as hepatocellular carcinoma, and giving bevacizumab for breast cancer, which has been, even the FDA is not recommending it any more, but sometimes we still seeing it. Misuse is giving palliative chemotherapy at the end of life. So, so you can actually provide both misuse and overuse. Sometimes can overlap. Doing surgery when you know that the disease cannot be resectable, or you're going to leave positive margins or progress disease, and using drugs for when you don't have the right genetic combination, like using cetuximab in patients with rectal cancer who have a RAS mutation. You are going to cause more harm than benefit. The harms overall for the patients at the micro level, the patient and their family, it could be physical, or it could be financial cost, harm to the organization, like the hospital, time of the workforce, financial costs, personnel resources, overburden emergency departments, and at the macro level, at the country level, and health system level, the resources that you could use for education or for prevention can ultimately impact the population health outcome. And one of the most important problems of or outcome impact of low-value care is lack of confidence in the system. And it's very important because it can result in patients not coming forward because they know that they will not get good care, or they bypass care, so they over-rely on the private sector and medical tourism, which is really impacting economy in Africa. And also it could be because lead to weakness of primary care system and huge impact on prevention and diagnosing the cancer early. And we know this from a recent Guardian article about the president of Nigeria going for cancer treatment in 2020 outside Nigeria, where we have very competent Nigerian oncologists. So Nigeria spends $1 billion annually on medical tourism, and the 4 key specialties are oncology, followed by orthopedics and the others. So there's a lot of money that needs to be saved in our own countries, and there's a lot and can also lead a lot of wastages. And so some of the wastages over treatment, failure to coordinate care, failure of care delivery, and fraud and abuse, and the pricing failure, or administrative complexity. And so if we look at cost, which is the other component, we are seeing more attention, luckily, in the oncology community to financial toxicity, out-of-pocket expenditure, catastrophic expenditure, such as a patient losing all their money or selling their houses. And that affect the whole community as well. And we are also seeing economic benefit of scaling up coverage and universal health coverage. And that was in the recent WHO report on cancer, it was really looking at value for money. And this involves economy, efficiency, and effectiveness. So economy is the cost of resources, efficiency is the relation between output services and the resources used, and the effectiveness, extent to which you can achieve the objective by using the resources that you have. And so the workforce can do two things. It can increase the value for the money, or can decrease the value for the money. And by increase it by providing evidence-based care, and decrease it by not providing evidence-based care. So if we look at all, these are our Choosing Wisely Africa recommendations. Most of them involve the workforce doing what is right and communicating that to the patient. And so we know that there are many ways patients can receive, may not receive evidence-based care. But let's look in particular in what ways, why does the workforce sometimes fail to provide evidence-based care? And what do we mean by evidence-based care? It starts from history and physical, assessing toxicity, so systematic patient assessment. You need to have accurate diagnosis, such as, for example, for breast cancer, you need to know what the receptors are. Is it estrogen positive, or is it triple negative? You need to talk to the patient. So communication is very important. You need to tell them about the intent of the treatment, the benefit of the treatment, the toxicity, survivor care. And then there's always a lot of information asymmetry, which means that we know a lot about the treatment while our patients do not. So there's a gap between what we know and what our patients know, and we need to bridge that gap by spending time and counseling them. And of course, we need to provide the treatment itself should be guideline concordance, and it should be value based. And so we can fail, two reasons to fail to provide best evidence-based care. One is that was coined by the Institute of Medicine. One is the no gap. You simply don't know. So that could be because you have not been trained well, or you have been trained well, but you don't have access to continue to train. Well, you don't have access to new journal, to the new articles, or to the new guidelines, or you have access, but you don't continue to update yourself, or you have inadequate self-directed learning skills. So after you graduate from your training, you don't know how to continue to train yourself without having teachers around. Part of it could be just a straight lack of motivation, laziness, or negligence. Or also part of it is that there is no regulatory mechanism that makes sure that all the providers, all the doctors and nurses are continuing to be competent. So monitoring of medical competencies. And then the other reason is that you actually know what to do, but you don't do it. So that's called the no-do gap. And we see that if you have really very high volume clinics and high volume workload, you're seeing 60 patients in an hour or in the morning, and they're all very sick, and they don't have, you don't have time to go over things. And sometimes it's easier to order that bone scan and discuss, oh, you don't need that bone scan. Sometimes dual practice for some people can be difficult. Such as having both private and public practice if there are not enough resources. And then inadequate quality monitoring. So nobody's looking at, are you actually following the guidelines or not, which is guideline concordance. And of course, it's everywhere, whether in high income or low income, there are some people who are just outright not motivated and or burnt out or lazy. And then, of course, there's inadequate training in communication, professionalism, and humanism that sometimes we can see in the workforce. And so it's all related to what do we need from the workforce. So it starts with educating them. And the most important thing in the workforce is we have adequate quantity, we have enough doctors and nurses, for example, so that they don't have too much workload. Quality, they know what they're doing, and relevance, they actually know what they're doing in the setting that they're in. So there's no need to train in cardiac transplantation if you can't have, there's no resources for you to do heart transplant in the setting. And recently, the competency framework has been updated, and this was published in Lancet 2022, just recently. And the idea is the competencies that the workforce needs start from foundational competencies, which you need to know. It's really like knowledge of theories and concepts, and then scientific competencies. You need to know the skills of practice of different professional specialization. And then what we need is a higher level of competencies, which are integrative competencies, such as complex abilities, critical thinking, numeracy, creativity, emotional intelligence, ethical deliberation, and especially communication proficiency. And I was discussing with some colleagues in Sudan recently, and we look at the medical tourism. A lot of patients from Sudan go to Egypt and elsewhere, and part of it is actually could be related to communication issues as well. And so we did a study, and that was published in eCancer, and looked at do we actually prepare our trainees for oncology, for practice. And we looked at, we asked them several questions. Like, this is a very long list. I encourage you to read the articles, such as, can you do initial consultation? Can you manage symptoms on toxicity? Can you provide supportive care? And so about 15 professional tasks. And we noticed both, the survey went both to high income countries and low income countries. And in both settings, the lowest was leadership and effective management of oncology practice and understanding the healthcare system. So this is what the trainees felt that they lacked, and therefore we need to instruct on cancer care systems and leadership, and we need to put that in all the curriculum. And so when we look at value and economic of healthcare and putting that into the training, this is not new. Sometimes, actually, I think in Africa we do a better job, because our trainees know how expensive the treatment is. Sometimes in high income countries, residents may not know how much this costs, but we do have a lot of challenges. So many, the curriculum in a lot of places is just syllabus, teach this, but it doesn't mention specifically teaching about value. And some term training programs actually put those as competencies, but we don't have a lot of information. Is it actually being taught, and how are we actually teaching it, and how are we teaching it? And if we are teaching it, are we actually assessing the level of the trainee and the program? Are they really trained in the end? So looking at some recommendations, for example, this is just to give you an example from the global curriculum in medical oncology from ESMO ASCO, and they do, well, that's an objective, the highest, to determine the highest value agents or regimen, an optimal combination of clinical benefit, toxicity, cost, and specific clinical application. So there's a lot of components. This is awareness, knowledge, and skills. So some of the knowledge is understanding the factors that underlying the rapidly rising cost of cancer cares in your own setting or environment in the world. Apply the value assessment tool, and use communication skills that facilitate conversation with patients and families. So we have it in the curriculum, and but we haven't in many times changed it into competencies, and that's why competency medical education is important, as the WHO guideline says. And competency, what is it? It's a habitual judicious use of communication, knowledge, technical skills, and clinical reasoning and emotions and values, and to reflect that in daily practice so that you can benefit the individual patient and the community as well. And we see that these competencies have made their way into some of the oncology training so in high income countries, but it's actually quite new. So we see that, for example, this is the American Hematology and Medical Oncology milestones, which is part of the competency-based medical education. Is only in 2019, but they do change it to various levels in the health system. So describe incorporate value and quality costs into shared decision making, manage financial factors that affect the patient access to decision making, and then how do you teach it? So there are first level, so this could be first year resident, and this could be third year resident. We have it in Canada also, and this was all in 2018. So it's all kind of new. Recognize the financial impact of diagnostic tests and treatment, use clinical judgment evidence to minimize wasteful practice, allocate health resources, and how do you progress along the competency domain, apply evidence and management to assess and achieve appropriate care. And we do struggle how to assess that. That's happening also in nursing. So this is nursing in South Africa. Some of the competencies use the change process to influence introduction of innovation and adaptations. So what is the difference between knowledge and competence? So we want our residents or trainees to describe how the clinical trials are done. This is knowledge. And then we want them to critically appraise the evidence. Is this trial good? Is this drug really good as they mentioned in the clinical trial? And this way, and then use that in their own practice, and that's what will be steward of resources. And that will, then you will have competence instead of just knowledge. And we did mention this previously. So we need to change from just syllabus in curriculum to actual competencies. And this is, as I said, new even in high income countries. The advantage is you can define how to, the milestones and the progression of competencies. You can select the educational activities and experiences, how you want to treat it and how to assess it. The disadvantage is sometimes it requires a lot of work. You need to train your faculty to faculty development to teach that, and require realignment of accreditation so that the way you evaluate your training programs. For example, the Republic of Kenya, in Kenya, they had a report on the task force of training medical specialists, and they wanted to make sure that their roles as leaders and modern health teams are not very well appreciated at this point, and we need to appreciate them. And they actually recommend the CAMED roles, which is a lot of you are familiar with, such as collaborator, scholar, health advocate, and professional. And that we need, as the medical specialists, need to do research, need to lead institution, need to develop practice in tandem, and also ensure quality standards of procurement, drugs, and consumables. And if you're using the CAMED roles, you need to, all of these can help you in teaching value, such as professional. You need to be ethical, steward of resources, avoid overuse, misuse, and underuse. You need to advocate for the needs of your community. You identify gaps and lobby for resources, and you need to communicate the cost of therapy to patients and educate them about financial toxicity. So how do I put it together in your training programs? You identify what the abilities you need your graduates, number one, and then explicitly define these competencies and their components, and say, okay, and define the progression, which means the first year residents should know this. The second year resident, by the time they graduate, they should know this. So that's a progression of competence pathways. And then you select the educational activities from journal clubs, from assessment in the clinic, and select the assessment tool, and you evaluate how your program is actually teaching this in the end. And so in the clinic, when you're seeing patients with your trainees, you need to make sure that they're practicing evidence-based medicine. You address common diagnostic pitfalls, and you can use choosing wisely guidelines. You encourage critical inquiry. You always ask them, is this the right test? Is this the right treatment? You role model. So the way you communicate with patients about value-based care and financial toxicity, and you make sure that what you're giving is actually concordant with the guidelines. It follows the guidelines. So some of the strategies that you can use is to encourage incorporation of value in cancer care and cancer economics into journal clubs, tumor boards, oncology society sessions, such as we did with aortic, recruit knowledgeable non-clinical faculties. You can bring pharmacists, you can bring health economic researchers. You enable research so that the residents should just not look at genomics and all of that. They should also, some of the projects should be about value and whether the patients are receiving good care, and also harness the power of IT using online learning tools such as this. There are ways for example, we are providing a master class in critical appraisal at Queen's, and we are collaborating with a lot of oncology colleagues in Africa. You can have a lot of, there's now a lot of literature in toxicity and economics of cancer care. And if the critical appraisals is like you're looking at the literature and say, is this clinical trial is really relevant to me? Is this drug really good? And so you need to enhance the competencies of oncologists to critically appraise new evidence. And then and the aim is to stewardship of resources. Assessment tools. So how much do we assess our trainees? I know I trained in Sudan, so I know that we depend on exams a lot, exam heavy. But in Africa, I would say there are more opportunities for observation of leadership, humanism, and engagement with patients. And because the trainees do a lot of work and they are very self-directed. So it's important to assess whether your trainees are doing overuse, underuse, and misuse, and provide examples for those to your trainees. And it's not really about fancy assessment tools, but it's really deliberate action and attention to what your trainees are doing in the clinic. You can also collaborate across institutions with your research institutions, such as this is the Khartoum, this is the big Khartoum Oncology Center, and across the street there's an Institute of Endemic Diseases, and we're hoping there will be more studies on value care, not just test tubes. Recently, there was an article that came out about the research priorities in LMIC over the next decade with Pramesh and colleagues. And number 3 is to emphasize country-level health economic assessment and of cancer intervention and technologies, and health financing and value-based care. So encourage your trainees and yourself to engage in this type of healthcare research. And in the end, why do we need to be humble? Why do we need to teach humanism and professionalism? Because our patients know more about their values and their lives. They are vulnerable to this information asymmetry, which I talked to you about. And we also need to understand that new drugs and technology are not always better. And if we understand the structure and national cancer care system, it allows us opportunities for advocacy and change. And hopefully we can use vehicles such as our Aortic Education and Training Committee, professional development, postgraduate learning, e-learning, and harmonization, and we can come together and really make a value-based care one of our primary objectives in the continent. And I will end here. And this is Khartoum at night with the Blue Nile and the White Nile coming together and forming the most powerful river in the world. So hopefully we will all continue to come together and with the aim of improving patient outcomes.